25 years back and it has gained great importance now, and probably in about 5 to 10 years time down the lane, dental implantology will be the only solution for replacing tooth. So when you design it or try to do a dental implant, you'll have to concentrate about the diagnosis and treatment planning and the anatomy and other things when you proceed. So these are all the various things you would like to do before you do that. Start with a dental implant. So you'll have to be aware of various diseases, and probably most of the patients who have lost their teeth so early will have some underlying problem as well. So in the present scenario, you can see diabetic patients, you will be seeing hypertensives, and of course other disorders. Always be careful to note that. So when you try to replace a missing tooth, you always find out why the tooth was lost. Whether it was periodontal, endodontic, prosthetic, or occlusal fractures. All these have to be taken into consideration. For example, a patient of about 30 years old lost his complete set of teeth and he wants a replacement. That means he is having some other problem, isn't it? That is why all the teeth are failing. And I'm sure that all the teeth will not go away just because of dental caries. So periodontal fracture is going to be a key thing in this, and then the resorption of bone is going to be more. So you'll have to calculate all those things when you place the implants. So pre-op imaging, the advent of CBCT has helped us to really decide things very well. The simple concept in implant is the tooth which you are going to replace. You think if it is a molar, for example, you choose an implant according to that. Of course, you should have enough bone width and height for that. But normally, if you see a molar is going to be more wider, so you can go for a 5 mm diameter implant, and the length in the molar region is going to be a little short, 10 mm. If the nerve is close, the next thing. But if the patient had lost tooth for quite a long time, so for example, the patient is edentulous in that particular region for about 10 years, there will be a lot of resorption. The ridge is going to be quite narrow. So you go for the advanced procedures, what can be done. So the nerve is going to be closer and the ridge is going to be narrower. If the ridge is narrow, you have to go for ridge split. If the height is less, you have to go for augmentation. So a very, very easy method to evaluate the placement of implants is going to be first take an impression and a dental cast. A simple dental cast is enough initially. Of course, the OPG and the CBCT can chip in later on. So once that is ready, this will give the thickness inclusive of the soft tissue and the bone together. So you can take something like a compass, the compass which have got sharp ends. You can put a little bit of LA or a topical local anesthetic, press it in and find out the thickness of the soft tissue. So now you know exactly how much of bone is going to be there, so that you can choose the width of the implant. So the model can be sectioned in the center and it can be mapped, the soft tissue. Actually, this is very, very effective, especially in case of mandibular anteriors, where the bone is going to be so thin and you've got a lot of structures on the posterior, on the lingual surface. You've got all the veins and arteries there. You really, really have to be careful, because if you perforate that bone, you're going to land up in deep trouble. So for mandibular anterior region, as I said, the ridge is going to be narrow. So you go for implants called as narrow platforms. I talk about the conventional implants, not the basal implants. So narrow platform implants means you can say it's about 2.65 mm or about 3 mm in length, in width, and the length can go about 10 mm. Don't think there is no other vital structure in the mandibular anterior region and try to put a 16 mm implant, even if the ridge is small, you will definitely end up perforating on the lingual side, nicking the lingual artery. So the study models are done, and the cast is bound, a lot of prosthetic work, because occlusion plays a key factor. Of course, you can find out using these balls, the stainless steel balls which you can use, and to find out the magnifying error. Because when you take an OPG and try to do that, there will be some magnification in that. So you place these balls there and take an X-ray, and you know the actual diameter of the ball, because you have it in your hand and you know the magnification error. So based on this is all the bone types which is available. So if you take an OPG and see, because we don't do a CBCT for all the implant cases right now in our place. So I think OPG is most, and then IOP also. You can see the bone pattern. If this, the marrow is sparsely placed, that means the bone is going to be soft, the cortex is very resonant. So try to understand the type of bone. As the quality of the bone is getting lesser and lesser, your implant stability is also going to get lesser and lesser. You will have to really wait. In that case, you go for delayed loading all the time. And for posteriors, it is always safer to have a delayed loading, because the occlusal force is going to be more. So this is a classification, Mish and Judy classifications. There are no oral surgery postgraduates here, I guess. And when you use the CBCT, this is one of the advantages where you measure in on-speed units. Through that you can confirm the density of bone. So the basics for fixed is 4 main buttresses, that is the main area where we have to do. The ideal implant diameters and other things I put, and for narrow ridges you can put 3.25 or 3.25. There's some basic concepts which you can have. Because the canine region is always used, since the canine has got a longer root, so you can have it. So the implant requirements are as such: 1 missing tooth, 1, 2 means 2. This is the order of these things. And then when you go for full mouth rehabs, you can have 6 implants or 4 implants, or sometimes the bone is more and other things, 8 implants. So there are 2 concepts in this. In one thing where the patient is completely edentulous and there is good quality of bone all around, you can put 6 implants. And that is called as the all-on-6, which has been patented by the Nobel company. Only they use that thing, all-on-6. If the ridge on the posterior side, if the height is very less and the sinus is so close, we will use 4 implants on the anterior side, and both this 4th implant on the side, both the 2 ones, you can angulate it in 45 degree so that you can increase the length of the implant which you are placing. And then to make it straight to emerge outside, you add something called as a multi-unit abutment. You understand? So 2 implants will be tilted. That is the tilt concept they call it. In Nobel they call it as all-on-4. And then when these 4 implants are made to project outside straight, that is when you add the abutment, now you can connect a metal framework above and the teeth are placed above. The advantage of using a metal framework is you can increase the ridge height, you can then remove the screws and service this thing also. See, when the patient spends a lot of money on the implant, and then you should be able to deliver or address the complaints as and when required. Just like I told you, you are doing some scaling often, yearly once or something, removing the calculus, you have to do service for the implants also. And then the aesthetic outcome, you just don't put in your implants and then leave the patient off. You need aesthetics also. So first one is patient selection and smile line. You should always know how many teeth are going to be exposed when this patient is smiling. And then the position, where the implant, the abutment is going to come, you should be able to predict. Sometimes what happens, the present scenario, we use screw-retained dental implants. That is what we do now. Before we used to do cemented implants, now it is screw-retained. So when this tooth is projecting out, and if your implant is not put in a proper angulation, when you add the abutment and put the screw, your screw will emerge radially. That is the problem here. That is why the angulation of the dental implant is going to be important. And root position of the adjacent teeth and the periodontium, the anatomy and the position of the implant is very important. So what is the outcome of the posterior implants? You should see the available space, the number of implants and the prosthesis as well. So the last picture will show you the screw retained implants, how it is emerging. But in some scenarios, you won't be able to really put the implant in the angulation you want because bone is not available. You have no other option for that. You will have to use the multi-unit abutments and then try to bring them into position. So some of the few points which you should keep in mind: the implant should be at least 1.5 mm away from the adjacent tooth. If the adjacent tooth is a natural tooth, the implant should be at least 3 mm away from the adjacent implant. Because whenever you put an implant, there is going to be some resorption before consolidation. So you need 3 mm. And always when you put the implant, put it a little below the bone level, because it will compensate for the resorption which is going to occur at the crestal level. Otherwise, what happens, there will be resorption and some of the threads are going to get exposed, and then there is going to be accumulation of plaque, and then there is going to be peri-implantitis. That is why if you see, the exposed portion of the implant will always be smooth, because bone cannot form there and the soft tissue cannot also have hair there. You understand? So the smooth surface is mainly to prevent that. The other portion of the implant which is settling into the bone is all treated with all these gamma rays and other things, because there should be good osseointegration. So sufficient crown height space must exist for harmonious aesthetic and functional replacement with the adjacent tooth. So when you put an implant and then you give us healing cap later on before you take an impression, it is going to give a good collar for you. And then when you take an impression, you can't take an impression with a normal antigen. You should use a putty impression material, the soft and the light body as well, so that it flows inside, you get a good impression. Then the tooth will give a good emergence profile as though it is coming right from inside. So you should know about the gingiva as well. So the key elements, that is one of the successful elements which you see, especially in the anterior region, the presence of papilla, then scalloped whatever type of it. So you always give a concentration on that. Suppose you are trying to restore an anterior tooth alone where there is bone loss. The patient had a history of trauma, he has got a lot of bone, and the patient wants the implant immediately. See, all the techniques in dental implantology has been formulated in a way to finish the treatment quickly. Before it was like if there's bone resorption, you take iliac bone graft, build up the bone, then you imagine a 65-year-old man lost all his teeth, you put him under general anesthesia, takes an iliac bone, to walk properly itself it is going to take another 10 days of convincing the patient is going to be really tough. That is why the all on 4, all on 6, all these techniques have come to help in forming the treatment as quick as possible. So this is one interesting patient of mine, about 86-year-old patient, severe cardiac issues as well, who had lost all his teeth, and his last wish was to have the complete set of teeth. He was very, very adamant on it. He wants a fixed teeth. So that is one of the post-op pictures. So what we have done is we went for the all-on-4 technique. Of course, it was done by my wife only. I check in whenever there's a problem. And then all these 4 implants in the mandibular anterior region. So once you put the implant, what you are going to do, you need to now fabricate. So what we do, we are putting something called as an implant analog. That is a replica of the implant. So that is attached to the top portion of the implant which is inside. And when we take an impression, this portion should come into the impression, isn't it? So that will have a screw, you can connect it, and you make a special tray with holes in the region where these implants are placed. So when you take an impression, this impression analog is going to project outside. And then once the impression is set, you loosen the screw, this portion is loose, you take the impression outside, automatically the replica is inside. And then what you do, you put the impression. You put the die stone or whatever. This implant analog is inside, and you can attach the abutment above and give it to the lab. So they can plan it properly and trim and do all the work required. So this is the thing which we did in the upper. Only thing is when you take impression along with these, there will be micro movements when you put the impression material inside. You should always tie it with a thread or something. Otherwise this will move. Even if there is a minor variation, the next step, that is, we'll make a resin, a pattern resin and all, pattern resin, and that will not be a proper one, and that is called as a jig, you call it. This is a wax pattern of the metal framework which we are making. Understand? So that will not fit properly inside. So this is that. See, we have tied it with a thread before we take an impression. But what we do is we make the pattern resin right there itself. You tie everything together, and then the resin is placed above, and the jig is ready on spot. That is how we shorten that particular time. So this is the thing which we do. Yeah? So with this, we get a replica of the jig. So when we take an impression, see, this is the implant analog. There is a duplicate of the implant which is inside the impression material. Above that, we put the die stone, and when we take it, we have the implant inside. That is an artificial, another implant, a duplicate implant is inside. And then we do it. Of course, occlusion and other things have to be considered properly if you want to give a successful treatment for the dental implants. Thank you so much. I hope I'm quick as well. Yeah.